My colleagues, Dr. Sharma, Dr. Kini, and associates to the room 6 of the cardiac cath lab. Dr. Sharma.
Yes. All right. Good morning. This is actually, I would say, the first time in our history of structural heart live cases that we'll show you the recorded case. And I think since it's not a true patient, we wanted to start as if we are doing the actual case, so that we're properly gowned with the lad, with the mask, cap, and everything. So with myself and Dr. Kini on my right side, then we have Dr. Gilbert Tang, our surgeon. Then Sahil Khera, interventional assistant director of our structural program, and Dr. Stem Larakas, who is a director of structural echo. So we basically, the case has been done a few months ago, and we will go through the process of same, that we want to provide the best educational value for our live case. So it is not live, but it's virtually live. That's what we are doing at present in our lifetime. And I think at least take the advantage of this. I personally going to remove my mask. I know we have the social distancing going to, but if they want to keep mask is okay also. And I can see AK has gone 10 feet apart. But you know, I barely, the people can hear. Maybe without mask, they may understand a little better. So with that note, we will start this now, today's presentation. Let's start with the slide set, please. Okay, this is partly sponsored by Abbott Vascular. And partly sponsored by Sharma's, our
private fund.
Yeah, Cath Lab.
Pointer.
Samin Sharma Family Foundation Cath Lab. These are our operators today, particularly in this case, which were with myself, Annu, Gilbert, and Sahil. And of course, the Stematous, and Pedro is doing the moderator. These are our disclosures as usual. And we start with this case. This case is the 74-year-old male who presented actually a few months ago with the initial event, but current event, which led to the current procedure, was that patient presented with acute onset of breathlessness and unresponsiveness to our sister hospital, and was found to be in acute pulmonary edema, cardiogenic shock, was intubated due to respiratory failure. Patient also has a transient cardiac arrest, but responded to vasopressors and resuscitated. So brief history, this patient has a hypertension, hyperlipidemia, AFib, had an inferior wall MI, and then also has, which required primary PCI, and month later has a distal left main bifurcation, stents which will show you, and has a baseline moderate MR. And these are the medications, the clopidogrel, apixaban, and by the time patient was transferred was on heparin and diuretic. The rest is all good, EF 55% with a moderate MR, which is the baseline. So we want to go through this. This is the case, actually Sahil did the case. Sahil, you want to just comment on this particular case from the interventional point of view?
Yeah, so he presented with an inferior wall MI, and you can see the mid-RCA is totally occluded, pretty much revascularized after the procedure. No complications. He was sent home.
Pablo,
he
did
wanted
the patient
to travel
come?
abroad. He's actually
Penya,
not from the
where
US.
is my lady? So put
and,
Taylor in the room 1,
He was
okay,
having
room
some
2,
shortness
okay?
of breath, so he came back to
Penya
me.
should go to room 1.
And at that time, he said he doesn't want to go for surgery.
Yeah,
so we
good.
went ahead. We decided to do the distal left main mini crush with Impella.
Okay. After second,
it was an uncomplicated procedure. He was discharged home the next day.
With angiography, it looks quite good. Now, at that time, the MR was only moderate.
Correct.
Yeah. So this event happened. That time, patient was present in cardiogenic shock. So now, when patient transferred here, patient has a severe mitral regurgitation, and we'll go through that. That heart EMA evaluation. Patient found to be in prohibitive risk. Patient intubated, had a balloon pump, and then question was that should the patient go for surgical MVR with a high, you can see the STS score of 8 and 15. And then question was that in this particular case, and this is in the era of the COVID, that should the patient have a surgical mitral valve repair? That is what patient, otherwise young, although it's in right now very high risk because of cardiogenic shock, or should get a mitral clip. So I'll ask now Gilbert from the surgical point of view that which case in this situation will be appropriate for surgical, the correction of the mitral regurgitation.
Well, even under the non-COVID condition, this is a very high-risk patient already for any kind of surgical intervention, I think, given the acuity. In the COVID pandemic, would this patient present during the peak? So there were no ICU beds available, and ICU resources were very scarce. So to subject a patient to surgical intervention and then a prolonged ICU and hospitalization stay, I think would do the patient a disservice, and also to our health care system resource utilization as well. So I think that's why we are considering a percutaneous approach for this patient.
And that actually goes back to one of the guidelines which I will share with you a little later in this COVID era about a recommendation that which structural case should be done. Now, Anu, you want to comment on this case now? From the MitraClip point of view, patient is intubated, patient has a balloon pump on low dose pressure and severe MR.
Yeah, I think if the heart team discussion did happen with this case, and I think rightly so, like all the discussion has happened that this case during this time, or if I'm not sure, even in the non-COVID time, this case probably would have benefited from a mitral clip in that acute situation, because STS, like you pointed, is a very high a patient in cardiogenic shock. So I think either way, I think the right approach was done here, that we got to plan with a mitral clip.
Okay.
Now, one question for Doc regarding the surgical evaluation. So the approximation of 15% very high risk or prohibited risk in this case scenario may not apply as in the stable chronic MR patient.
Right.
Of course, because these patients will have a mortality that is way beyond 15%. So in that sense, when do you operate, or when do you actually propose the clip for this kind of patients? Dr. Gilbertang.
Well, I think clearly everyone agreed that this patient should not undergo surgical intervention unless absolutely necessary. I think that we are established already. The next thing is, and Stam can comment that once we looked at the echo, is the anatomical feasibility for the clip, right? And Dr. Kinney and Dr. Sharma, Dr. Kara, and we looked at these echoes with Dr. Lorakis in detail. And if the anatomy is suitable, it's worth a try. There's also a philosophy now, and there's some literature talking about this. It's called bridge the decision. So you stabilize the patient, reduce the MR burden, may not be a perfect repair, and then once the patient is clear, then maybe come back electively for reintervention if necessary. I think that's something that we should consider as well during the COVID era.
Okay.
Very good.
Okay. So
Let me go back. I think, Gilbert, even in the non-COVID situation, in an acute case like this, there are case reports, and I think that's what will be practicing.
Correct. Yeah.
Somebody coming with cardiogenic shock and acute MR, whatever the etiology, if a clip is anatomy is favorable, that's the way we should be approaching these cases now. Like you mentioned, it's a bridge, like we do a bridge BAV, do a bridge. Clip, and he's a young guy, stabilize him, and I know we did PCI, so okay, if this comes back with restenosis, it's time he goes back for a proper revascularization and probably surgical MVR, or he will be better the way he is now.
I think Dr. Kinney is bringing a very important point, and this session will be guided to convince you that the first approach, probably equally important to this disease, may be percutaneous in these days and age.
And that actually goes back to one of the updated focus guideline of the structural heart intervention, which we again will allude to. But the other point is that something acutely happened.
Yes.
Right?
Yes.
Stam, what do you think? Because it was moderate and now patients florid pulmonary edema, and we know the coronaries were normal.
Yes.
So what do you think likely etiology of the severe MR now?
So if you will see on the images, there is a rupture of one of the heads of the posterior medial papillary muscle. As you can see in the top image very well, on one of the heads of the posterior medial papillary muscle is ruptured, and you get the feeling that there is a FLEL anterior mitral valve leaflet. And you can see the gradient. We measured the gradient before we start, and the gradient I think was about 2 millimeters mercury. And then we check the pulmonary veins on your left. You see the right upper pulmonary vein, and you see blooding of the systolic wave. And on your right lower, you see the pulmonary vein, the left upper pulmonary vein, and you see systolic reversal. Very specific finding for severe mitral regurgitation. So this patient, even without to put the color, will have severe MR because of primary, actually, mitral regurgitation due to the rupture of one of the heads of the posteromedial papillary muscle.
Okay, so that actually explains the acute deterioration, and this is your fancy 3D TEE.
Yeah, so this is again on your left, you see the flail actually is A2 and A3, mostly A2 flail scallop, anterior middle scallop, and on your right you see the severe, actually more than severe, torrential matral regurgitation on this patient, and that's why he was needed a balloon pump and he was in the ICU.
So likely his MI caused it.
Yeah.
The inferior MI
Very
that he
delayed
had initially,
Complication, yeah.
and which is one of the late presentation, despite he had PCI within 90 minutes.
Yeah.
So
Yeah,
this-
original PCI,
Yes,
then
RCA,
left
MI,
PCI.
yes.
But this actually, if you say the time frame point of view, this had happened now 6 weeks after the first primary PCI. 6 weeks.
Yeah.
But maybe the muscle, the
Ischemia,
papillary
yeah.
muscle became a little soft, got partly necrosed, and then maybe he was doing some activity. You think the Sahil, that something precipitated that event for this patient, or just went acutely?
He's very active gentleman. Otherwise, was doing his daily chores, was practicing social distancing. He was walking in a garden. I mean, he wasn't really out of the ordinary person. I don't think there was any inciting event, if you will.
Okay. Now,
yes. So
what is this now?
this is before we start, we usually measure the length of the posterior leaflet just to know how big it is in order to decide what size of clip to use, because now we have two options. So these are some measurements, and also we use these measurements to know after we put the clip on, before we deliver it, if enough of the leaflet is captured, is gripped on the clip. So we know if we have adequate grip and if we'll be successful and to prevent dislocation of the clip. So that's what we do, and we publish about this recently.
okay.
So what
now
is the length that you will recommend, Dr. Lerakis?
Yeah. So basically, it depends on the clip. If it's a small clip, we want to have at least 7 millimeters in. If it's a bigger clip, 9 millimeters. So
No, he's asking what should be the leaflet length,
yes.
so
Yeah.
you can consider the patient is a...
So you should be at least at least 7 millimeters to start, but preferably 10 millimeters.
10. And we'll come back to that ideal, the grasping or the ideal mitral clip cases and so on.
Length.
Grasping
Beautiful.
zone
10.
length. Yeah.
10. Beautiful. Now, bicable views, the same.
So this is a bicable view, very important view for the transeptal puncture. On your top left side, you see the superior vena cava, which is the superior part of the septum, and then on your left you see the inferior vena cava. So you have the superior and inferior part of the septum, and then on your right you see the short axis view, and where you see the aortic valve, and on top of that is the anterior part, and on the back is the posterior. And on your bottom you see this was before we do the transeptal puncture, where there is a tending. We want to have the appropriate height from the plane of the mitral valve, because we want to be able to manipulate the clip going in. So, and the recommendation for that is for the distance between the plane of the transeptal puncture and the plane of the clip to be at least 4.5 centimeters in order to be able to do the procedure safely and also to be able to manipulate the clip.
Okay, good. We keep going forward. This is the transeptal, and you want to comment on it, how difficult or simple it was?
So you see that some fluoroscopy guidance is always essential to see exactly, which way the transeptal needle is facing. But echocardiography, well, like he mentioned, is very important, that you have to first see it is anterior, posterior. You see it is right in the center, and then you should be also making sure that you are not too anterior, posterior. You see on the left side image, you see the aortic valve on the right side that's opening, and they are just ready to check the point where they're going to puncture, that it is posterior enough. You don't want to be too posterior, very close to the atrial wall. So they're just confirming that it is at the right size, and once we say it is yes, he will go next. I think he will go to get the height.
Yep.
So wherever you see the pointer is, and then I think you're measuring, right? You'll measure to get us the height of the, you have the height?
Yeah, the height that was on the previous slide.
Okay, you add it on
was
the
more
right
than
there. Yeah.
4.5. So
Yeah.
Somewhere here.
So once we have done the transeptal puncture, then you will have the guide into the LA.
Take it out somewhere here. Okay.
And
So-
I think what they're showing on the right side is the same, the fluoroscopic view, to make sure your trajectory is correct and the clip entering into the left ventricle.
Okay. All right. So now, first clip grasp.
yeah, so this is most important view, bicommissural view on your left, where you have the lateral part where you see the appendage and the medial part on your left, and on your right you have the anterior and posterior, and you can see the clip on because the location of the most of the flare leaflet was A2 and A3. We wanted to do more medial, so the first, as you can appreciate, the first clip is medial, mostly medial. On your right, you see now that actually the leaflets are attached to the clip, and also you can see the grippers. You can appreciate the gripper to the anterior leaflet. Actually, you can see it going up and down when they try to close the clip in that location.
Now, this case, I know that almost now 45-50% of cases, we are putting 2 clips and about 5-10, maybe 3.
Yeah.
So this case was planned as we are going to put 2 clips based on the anatomy?
Yes,
Mhm.
yes.
Right?
Yes.
Okay. Very important. So clearly that, and that actually I would say has changed overall outcome of our mitral clip procedure over last few years, that we are putting more clips, and idea is try to bring as little as residual MR, 1+ or so, and that will be, rather than having a 2+ successful MR, a successful mitral procedure is counted as the 2+ or less, but I think it should be probably 1+, and that is what everybody is striving
Yeah.
for.
Now,
Dr. Kinney, you wanna
I
comment on the clip?
know, I know he has, Dr. Lirakis is going through, STAM is going through every single step of the echo, and you are going to subsequently show, even in the guidelines, you know, they have mentioned what are the echocardiographic views and what are the echocardiographic criteria that should be looked, that everybody should look for before you know that this is a candidate for a mitral clip. So it's very important for the, you know, this webcast. It's not only for interventionalists, even for echocardiographers should be watching this, so that he's going step by step exactly how TE has to be performed. This case is a case where you see very little fluoroscopy. We all depend on the echocardiographers to give us the right view, so that we are doing the puncture at the right place, and also grasping. At the grasp has to be at the right grasp, and they are the one going to tell us that is it in the right place, ready for release of the clip, versus we are not in the right place.
Gilbert, you're making some.
No, I was just asking Dr. Kinney, what clip did you decide to use here? Was it the XTR or the NTR?
This was initially
XTR.
was
Two XTRs.
two XTRs,
Yeah, that's right.
Okay.
large ones. Yeah.
Yeah,
So just,
that's
I
all.
know we are going to go back to those clips, but you want to make some difference of that why XTR versus NTR?
That should be your initial picture where
Okay.
your, you know, we went
Yes, Stan, you
behind.
want to comment XTR versus NTR in this first clip?
Yeah. Well, I mean, depends of the gradient.
Okay.
Depends on the length of the leaflets. Depends on how big is the annulus. So all these are determinants.
So I
what you
think the
use.
two important determinants is the length. That is why I think Dr. Moreno's question was the length of the posterior leaflet, because I think subsequently you'll show the difference between XTR and NTR. You will see there's a difference in this clip. So the posterior leaflet length and the annular dilation
yes,
length.
yes.
These are the two important factors. If your annulus is not dilated, you cannot go with a larger clip. So that's why I think during TE we all have a discussion and then we make a decision. And I would say 98% of the time we go with what we have decided. Yeah.
Okay, this is the first clip on
Yeah.
3D view, but it's grasping, mitral valve gradient.
Yeah.
Stan, what are we looking at it now?
Yeah. So basically, before we deploy the clip, as you can see, the clip is still hooked on the catheter. We check for mitral regurgitation, where is the residual MR coming from, and also we measure the gradients. We want to make sure that we don't cause mitral stenosis. So these gradients were low, I think 2 and 3 from what I can see. So there was a residual MR in more views that we don't show for the index of time. So we decided to go and put, and the MR was coming lateral to the clip. So we decided to go ahead and put a second clip lateral to the first clip, and that's what we did.
Okay.
So
Also
anything
very
gradient
important-
less than 7 is all right, right? What is usual? What is that gradient which you'll say I should not put the clip because now I'll trade off stenosis to regurgitation?
Yeah, so we go up to 4, 4, 5
First clip.
maximal, so that's what we...
First clip is a 4, I mean less than 4. I just have to mention to you also in that picture, you go back, yeah, here, the one that where you was measuring, so if you see here, other thing also very important, not so much in this guy, but when you are doing maybe secondary MR, when there is a dilation, where we think by 3D as well as 2D that this is the right place, things can move, and MR actually can get worse based on the how much leaflet has been grasped and all these things. So that is why this is very important evaluation before you release.
Yes.
This is the time he will tell us, yeah, it is in the right spot, or you go a little bit medial, little bit lateral to what our decision was.
Yeah, so this is the pulmonary vein flow after. On the top is the before, the bottom is the after, and you can see already you have improvement of flow in the right upper pulmonary vein. You still have a little bit systolic blending, but on your right, where is the left upper pulmonary vein, you can see already with the first clip, you don't have any more systolic flow reversal. Actually, it's almost normalized. That also tells you more subjectively that you have improvement of the mitral regurgitation. And so we use this all the time, not only the color, but also this is very important to get more evidence that you are doing the right thing.
Good. So this is the first clip. Things looking okay so far, but then you said you're trying to, what are you trying to do now?
So this is after the first clip is deployed. As you can see, we're waiting for the clip is deployed, and now the catheter is back into the left atrium, the guiding catheter, and we're waiting for the second clip to come up to cut it down again.
And right here,
right
the
there,
second
yes.
clip has come.
Yes. So the second clip, as you can see, is lateral to the first clip. That's where we wanted to be, and we start the same process again. On the right, you see again. These are the two important views, as I told you, the bicommissural view and the 90 degrees on that, medial, lateral, anterior, posterior. You can see the clip again with the leaflets attached to the second clip.
Okay. So now post second clip, how does it look now?
Yeah, this is now, still the clip is not deployed, but it looks very good fluoroscopically and by echo.
So we went lateral, second clip was lateral.
Yes,
so
lateral.
You see that in fluoroscopy, actually when you are doing second clip, fluoroscopy is more important than echocardiography, where you will know exactly how the clip is, behaving and how it's going to go. You have to check the trajectory, everything. Fluoroscopy is important during second time.
Okay.
And now it looks very good. Yeah.
And now this is what you have now.
Yeah, so this again, checking the clip, checking with color. As you can see, a significant reduction of the mitral regurgitation before the clip is deployed. And
it looks like everything is going good.
Yeah,
so now you're ready to deploy the second clip, and this is your 3D imaging.
Yeah, as you can see, two clips on the 3D image, two orifices, and as you can see, minimal mitral regurgitation.
Okay.
And the most importantly, I think, Stan, we can point out that the flare segment is gone.
Yeah, this flare
segment. I think that's what we can also visualize on the 3D, right? That you see.
It's gone. Yes, yes. It's in the clip.
Okay. So the regurgitation has significantly reduced now.
Yes. Yes.
And 3D imaging post mitral clip.
Yeah. So you can see on the top where we started, massive MR. On the bottom right, minimal MR. So
beautiful. Okay, see now here just puts everything together with your two clips and what residual things are left in this particular case. And now question comes is your ASD issue.
Yes, so this is the bicaval view on the short axis with the aortic valve anterior posterior. You can see that there is the ASD with left to right flow. There is no right to left. All the flow is left to right. And some of the time you have to decide if you have to close this or not, especially if you have right to left. But this is absolutely left to right. And we measured with 3D the size of the residual ASD, which usually closes by itself after a few weeks.
Which were very small. So, Sahil, I know that we have been doing some ASD closures, post-mitral clip or TMVR. what criteria we are using? One is clearly there is a right to left shunt, and what else?
Right.
Size.
So yeah, the three things that come into mind. One is if you have a discernible right to left shunt. Two is if it's a very large shunting, even if it's left to right, more than 1.5. And third is actually bidirectional shunting with hypoxemia. If your patient becomes hypoxemic, I think that's like the strongest indicator that you should close it. And I think that's what everyone does across the nation.
In the COAPT, actually, it was done in about 5% of cases. But now I think the threshold has become a little different, right? We are doing a little more. What percent we are doing now?
But the concern is mostly there's some data suggesting if you have very bad right ventricle, if you have severe TL and pulmonary hypertension, they don't do well even with a left to right shunt because of our right overload. So we see how the patient does at the end of the case, and we go case by case basis.
So roughly, if we had to give the number to our audience, what will be acceptable? 20%, 25%, 50%?
No, still very low. I would say
Very low.
well less than 10%.
Yeah.
Okay, less than 10%.
5 to
Okay,
7.
good. Now let's come to talk about this point. This is where the fourth generation G4. Now, who is the master in it? Who can describe what we are seeing this?
So essentially, if you see here, which we talked earlier, whether it was NTR or XTR. So that is number 1 and number 3. Those are the ones that were available. Okay, so that's what the decision was. There is a definitely increased length in the XTR by few millimeters. So what was G4 is that there has to be another picture. Essentially, what you see is that now there are 4 clips that are available. So what they've made is they've used the word W. So compared to the previous clip, which is on the left side, the leftmost, this has a wider. The clip side is wider, so the grasp would be much easier, but otherwise the length has not changed in G4. Then you go minus. Yeah, and then controlled grasping. So what happens? Controlled grasping means right now what we have to do is you have to grasp both the clip at the same time. So what is going to happen with this new generation? You can grasp at a different time. If you think your grasp of the anterior is good, you can just grasp that, and then you can make some movement so that your posterior grasp you can do separately. And continuous left atrial pressure monitoring, which we have been doing. Actually, I think our team was the first one to publish it, that the left atrial pressure monitoring can be done through the guide. Very early part, people used to do true transeptal puncture and leave a pigtail, 4 French pigtail to get a continuous monitoring. But then they, adopted that into this generation. So you'll have a continuous left atrial pressure monitoring. And other thing that is also is that the delivery system is designed in such a way, which you did not change, that you do not have to release the gripper line separately.
Okay, so let's come back.
So this is the 4 changes that they have made, and then you can go to the next one to exactly see the change, the wide. That's why they put the word NTR, NTRW wide, XTR and XTRW, which is wide.
Okay, so basically, how big this advancement of the clip is that you are able to now grasp individual leaflet. Is it a big advantage or it's just so advantage? What do you think?
I think some advantage we might have. It's not that you can grasp, release, and then go to another place. No, you cannot. It is still attached. You're not completely, dislodge the, not completely release the clip. Right? You grasp, then you can make some a little bit movement to the other side.
I think it gives everyone a sense of comfort. Okay. That you have enough leaflet insertion to avoid the SLDA. I think that's the main advantage of this feature. And also for patients with, like what Stam said, dilated annulus, with a coaptation gap that's difficult to reach, this might also be beneficial.
Anything extra in this slide?
No, I think the other thing which that's the same even from before, the width, whether it is at 90 degrees, right? Or 180 degree, 120 degree and 180 degree is 17 and 22. That I think was there from before also. Yes.
Yeah, I think Stam's point is very important about mitral stenosis. So, with the wider clip, you might be able to reduce the MR good enough with just one
But
clip
you may
rather
get-
than two,
Yes.
right?
Yeah.
So I think, and also at the same time, not have such a high gradient. I think that's another
Yeah.
beauty of this. Yes.
Okay. So therefore, this is the important that triage consideration of patients referred for structural heart disease intervention during the coronavirus disease of 2019 ACC Sky statement. And as you can see, this is a statement basically was that which patient should get at present and the tower patient very symptomatic, but more important is from patient from the mitral valve point of view that mitral clip. One patient with severe FMR, 3 to 4 plus, who cannot be safely discharged despite optimized guided line directed medical therapy by heart failure specialist, which makes sense. Second, outpatient with severe FMR, hospitalized for CHF within 30 days despite optimized guideline directed medical therapy. Then inpatient with CHF and severe degenerative MR due to acute valvular dysfunction who are high risk for surgical MVR. Our patient may fit into there, but there is another category. Patient with severe DMR hospitalized within 30 days despite optimized medical therapy and are high risk for surgical MVR, because these cases, if you wait few months, they may deteriorate. And lastly, I think this could be our patient, the patient with either severe DMR or FMR who are in low output decompensated heart failure requiring ICU level of care, where edge-to-edge device implantation might improve hemodynamics for extubation and or transfer out of ICU setting. This patient, even if you, because young person, you want to eliminate MR, even if you were not able to bring, you only brought it to 2 plus MR, it's okay to do in this particular case, although our case did an excellent, has only minimal MR at baseline, I mean post-procedure, so this was appropriate case to fit into the category number 5 that, and then can get a definite mitral valve repair later on. Everybody agrees on that?
Yes.
Okay. So then they say valve in valve TMVR is about the same issue that who are symptomatic, paravalvular leak closure also. Now they also said that PFO, ASD, left atrial appendage and L-core septal ablation should be deferred. And also that the patients who are in the various trials require intense monitoring, they should not be done unless essential. And most important, actually, I wanted to point this one, as you can see, that management of these patients had to be done by every week phone call. So this is very important. So key is that you have telehealth visit of these patients to be monitored. Very important for their long-term safety. Once they start deteriorating, then you bring them early back into the business, to the hospital. So with that note, I'll just go through a little bit of our discussion on the mitral clip outcomes and updated in terms of recommendation. Everybody is aware of the COAPT trial presented by Greg Stone, and it was a very emotional scene 2 years ago in TCT when he presented with a guideline directed medical therapy versus mitral clip plus guideline directed medical therapy, randomized 1-to-1, about 600 plus cases. And this came actually at heel of a negative trial about a month before MitraFR. And once the COAPT trial came, and which everyone is well aware of the results, they presented 3-year data now, that whatever was at 2 years, continue benefit at 3 years, nothing surprising. This is a hospitalization for heart failure. Then for all-cause mortality, they continue to do benefit in terms of patient with a mitral clip. So what I'm going to show here is a little different. You combine both, of course, you get added benefit, and these are the individual adverse events, all favoring mitral clip. But more important is this. So what they did is, after 2 years, the patients in the guideline directed medical therapy, knowing that 169 has already died, so patients who remain alive and who are appropriate, they had a mitral valve clip crossover. As you can see, 53 patients and 5 were done before 24 months. So total crossover was 58 patients. So basically we want to see that you are in guideline medical directed medical therapy, you failed. Now you go to the mitral clip and you remain alive. So question comes, and it was a very important question, that now putting a clip, is your outcome still will be as good as would have been mitral clip at the baseline? And guess to everybody's surprise that yes, very good. See this now? This is your guideline medical therapy group on top, and this is a crossover, and crossover outcomes were similar to the clip. So to about 12 months. So average, your median was 7.7 months. So just to say that it's okay. the patient's guideline, as long as you're following those patients, and then when the time comes, you put a clip on those patients, and these patients will be requiring, of course, strict vigilance from heart failure doctor and so. Same way for the mortality, and if you combine both of them, the message is very clear that even the patients after 2 years, they got the clip, their outcome was similar to as if you started the clip at time 0, and so. So therefore, now I bring down to this point, and I'll ask our expert echocardiographers here to comment on the 2 major trials which have been part of the controversy, the MitraFR outcome and COAPT, and this is actually very commonly used presentation, publication in JACC imaging about disproportionate and proportionate MR. So I'll ask, start with the STEM, and maybe I'll then ask others to comment on it. Stam, tell us, I know a lot of people talk about this disproportionate and proportionate MR in simple language, not echocardiographic or scientific, in a general statement. How do we convince people that COAPT trial was positive because of this and MitraFR trial was negative because of this?
Yes, so I mean the thought is here is that the MitraFR trial, they had the more sick ventricles compared to the severity of the MR. While in the COAPT trial, they had the better ventricles, meaning better EF, and more and smaller ventricles, more healthy ventricles for the same atrial regurgitation. Actually, the mean EROA for the COAPT was 0.4, actually, and while the MitraFR was 0.3. So actually, if you go back and see, COAPT patients had more MR than MitraFR. But the difference is that the ventricles on the MitraFR was bigger. The diastolic diameter were much bigger than what was on the COAPT, and the mean EF was almost the same, 30% in both patients on the MitraFR from 15 to 40, on the COAPT from 20 to 50. So I think that's the theory is that MitraFR had more sick ventricles for the level of the MR, for the degree of the MR, where the COAPT was better ventricles, but more MR, and that's one possible explanation. But I think it's more than that. I think it's most likely
and other things also. Gilbert, you want to comment on?
Yeah, no, I agree with Stem. I think we have to look at the patient and the echo. That's why echo is so key in looking at quantifying the MR, right? I mean, there's a different ways to quantify. You have to quantify it accurately, and you have to make sure the patient is dry. You can't do the patient when the patient's completely overloaded to determine the MR severity.
Anu, you want to say?
Yeah, I think biggest difference was in MitraFR versus COAPT guideline and directed medical therapy was not part before randomization. So COAPT was very clear that you got to have medical therapy, and we all know mitral regurgitation patients do get better when they get medical therapy. So they were on guideline directed medical therapy, and if they failed guideline directed medical therapy, then only they got randomized into medical therapy versus MR. But I think for disproportionate versus proportionate, the biggest, I think what we can say in simple term is the same. You wait for burnt out LV versus you do not wait. So in FMR1, they were not on medical therapy. After the mitral clip, then they put them on medical therapy. And like Stam mentioned, they were actually very late presenters. So dilated LV and MR actually was proportionate to how bad the LV was compared to COAPT. LV was, size as well as function was better than the patients in FMR.
So for the
let
audience,
ask Sahil answer, and then we'll complete with your message.
Yeah, so it's a very interesting concept. If you index the EROA to LV/EDV in MitraFR, the value is around 1.2, versus in the COAPT it was above 2. So this is a sort of moving target which Milton Packer and Paul Graben are working on, and sort of discerning if you can identify patients who benefit the most from MitraClip, because if you have much severe MR, which is disproportionate, then MitraClip and CRT is more beneficial. And if you have more LV failure and a proportional MR, then something like decreasing the LV volumes, like an LVAD, is more beneficial, or medications are more beneficial. So this is still a moving target, but I think it's conceptually very sound that patients who have disproportionate MR will benefit from resynchronization therapies, either through MitraClip or CRT.
Okay, you say, Moreno, you have some point?
Yes, I think this point is very, very crucial for the decision making on as a clinician when you decide to recommend these therapies. So the question will be in the patients with proportional severe MR, can you re-stratify a subgroup of them in which those ventricles may come back and will benefit from this technology?
And I think the point is very well taken. I give the example of our simplicity renal denervation trials. So you know after the little excitement, then they did the sham controlled randomized trial of refractory hypertension. Patient needed to be on 4 drugs. Guess what happened? It was negative trial. So key is that once you go to that extreme, when your ventricle has just dilated and even your EF remained the same. EF was equal in both the trials, but cavity was more dilated in MITRA FR, and then of course your MR degree was proportionate compared to compared to our COAPT trial, where LV cavity was not that dilated, and that's what they're calling MR disproportionate. So key is that now same thing. The renal denervation trials done off med and on med trials are positive. So see, the one major trial was negative simplicity 3, and now off and on med trial of simplicity, they come back positive. So basically what message is that grab the patient, stratify the patient, bring the patient for therapy before it is too burnt out. Very simple.
Excellent.
Okay. Yeah, with that note, let's go to the next point. And that was another point which they did is the health status change. You know, health status is very important, both mental health and physical health. Now this, in the COAPT trial, they use actually Kansas City cardiomyopathy quality overall sum score at 1 month, and then said that whether this 1 month our KCCQ score translate into outcomes at later date. So we know the death, recurrent hospitalization better in the COAPT trial. So is there any other parameter? So this actually is the quality of life parameter of the KCCQ, just published last month in JAC, presented last year. So it basically showed that many patients did have improvement in their KCCQ score. Some of them even have more than 10 points. And key is that if you take that more than 10-point score, improvement happened in 58% in the MitraClip group, and in guideline directed medical therapy group also happened, but only 26%. So this is KCCQ was done at 1 month. Now guess what? After it is done at 1 month, look at the 2-year follow-up of those patients. Death or heart failure hospitalization. There is a big difference that if you improve 10 or above, which is the lower 2 graphs, or if you did not improve less than 5 or did not improve, there is a difference of 40% versus 65% of death or repeat heart failure hospitalization. So just to say that if patients did improve on the questionnaire, they really did better on long run. And this is a very interesting, and actually they also show that it was independent of the treatment assigned. If you improve your KCCQ score of 10, whether you're on guideline medical therapy or you were in the MitraClip, your outcome was similar. So it was the basically health status of these patients. Really, maybe that is one of the factor may come back if they go back to some kind of assessment in the MITRA FR, that what happened to these patients and so. And this basically puts it together that health status change improved or predicted 2-year outcome, which was done only at 1 month. And this actually the nice editorial, they go and pro and cons of these KCCQ parameter assessment and so. Now then I just come up with a few important points. We still have a few more minutes. That is, we have the focused update of in 2020 about the expert consensus decision pathway. And what they did is they added 6 new things. 1, clinical and echocardiographic assessment. Then establishment of MR etiology, primary, secondary, and mixed. Remember in the past, nobody talked about mixed. Now they really brought the mixed and the mechanism. Then consideration of associated hemodynamic consequences. Then recognition of the indications for surgical or transcatheter intervention. And appreciation of the increasing complexity of surgical mitral valve repair as a function of pathoanatomy. And lastly, understanding of the current role for transcatheter mitral valve S2S repair using a clip device because of the 2 trials which have been positive. And these are the focused update on the right side, which I'll go through a little briefly. And this actually is a very nice, this is unchanged. Little bit of, they added a mitral clip, that how do you manage pathway for management for mitral regurgitation, from identifying, define, assess, treat, and follow up. And they actually put an importance to 2 group of the physicians besides those who are interventionalists and heart team, is the cardiologist referring who is managing these cases, and then the heart failure specialist. So had to have a very important role in managing these cases and appropriate patient then being treated. The second issue, which they added, this mixed etiology. And you can see here, the mixed etiology is many times it is not clear. So let's ask Stem on this point, that what is about the mixed etiology? Until now we were taught only either there is a primary or functional MR or degenerative or degenerative MR. So what is this now? People talking about the mixed etiology.
Well, I mean, some patients, especially on the functional mitral regurgitation, have also degenerative changes on the mitral valve. So I think we see the mixed etiology mostly on the functional MR than on the primary mitral regurgitation.
Okay, Gilbert?
Yeah, I think there's also those patients with primary MR that has dilated ventricle and EF is down because they, like you said, came in too late for presentation. So clearly there's a mixed feature as well. They have some restriction, but also has some primary pathologies.
Okay.
So, Dr. Sharma, we have some questions, very exciting. Right. The first question is to Professor Kera. It comes from Mike Brendan. Mike, thank you for sending your question. And it is, what are the causes of high gradient across the LA and the LV in the absence of MS? Can we diagnose pseudonormalization by cath? Professor Kera.
Yeah, so that's a good question. You can sort of not have MS, and you could just have falsely elevated gradients across the valve because of the flow. So you could have torrential MR and still have high gradients. And routinely, we don't measure these gradients by cath, post-procedure, but echo is sufficient. So our cutoff is we don't implant more clips if it's more than 5. That's our benchmark.
And also what has been written about, documented, that many times this pulmonary hypertension patient, you develop pulmonary venous hypertension and for the artificial gradient, and therefore with our policy in the cath lab, once your wedge pressure is elevated and you have a disproportionate, actually even if you have proportionate EDP high, we always give nitroglycerin as well as Lasix IV and nitroglycerin pulmonary artery, and therefore with the SWAN, and then pressure goes down if it is a venous hypertension. So clearly the falsely elevated gradient will be answered by taking care of the vasodilators and additional diuretics on the table when you're doing the hemodynamic assessment.
Fantastic. The second question is Dr. Sandeep Singh. He's asking if our patient was on mechanical support during the procedure or if the patient actually responded to medical therapy.
Sahil, your answer that?
Right. So the patient, as soon as we put the balloon pump, the inotrope requirements had gone down, but not completely. We still needed to maintain him on inotropes and pressors. I think it was a combination of both medical therapy as well as balloon pump to sort of initially stabilize him, but there was no way he was getting extubated and getting off a balloon pump without any definitive therapy, whether it's a surgical repair or a MitraClip.
Yeah, so going back to the question was not a mechanical support, but if you consider balloon pump, which part of a mechanical support was only balloon pump. But if you are trying to ask for impel or ECMO, no.
But yes, that could have been the next. No, that could be the next. Yeah. If you're a refractory case, you may have on way to the heart transplantation may require ECMO. And so if patients cannot have, let's say, mitral clip, cannot have surgery, some of those cases may go through the pathway of ultimate surgical treatment, which is impossible. So then may just get a heart transplantation.
But in this patient, remember, early decision was made within 2 days that patient was a good clip candidate. That decision was clip versus go the route of a mechanism which is ECMO versus temporary LVAD. No, so
Just a few comments before Dr. Sharma beautifully close. I have to mention 3 issues on the literature on these cases of acute myocardial regurgitation in the setting of acute myocardial infarction. The first is the trial that is going on in Spain. It's actually a natural history treatment with this device from Dr. Perez del Prado. You can see it in clinicaltrials.gov. The second is the differentiation between mitral papillary muscle dysfunction versus papillary muscle rupture. The 5 cases published in the literature were from papillary muscle dysfunction with 80% survival at 1 year. Only 20% mortality, only 1 case died, suggesting that for dysfunction, this technique is actually pretty good. The second, for papillary muscle rupture, only 1 case published, which was on ECMO, and the patient survived. And this case, which is a papillary muscle rupture, will be actually the second one that shows excellent results for this device, Dr. Sharma.
Well, we definitely should publish that.
Yeah, we are writing it up.
Case. Yeah. So this is just an algorithm, but more importantly, we want to go to this point, and this actually, I want to spend a little time into it because this is the edit for the primary MR, which we all very well know, that patient with the high surgical risk assessment, and if they are not a patient, not a candidate for surgery, clearly the TMVR with the MitraClip comes in, and if patient has end stage and everybody feels a lot of comorbid condition, then maybe medical therapy continues. The more important is on this point. This is what added now in this basically the upgrade of this consensus statement. As you can see, the patient, as this patient immediately was, it was very dramatic from that point of view. Didn't have a time for the CRT, but patient with the ongoing symptom, particularly for the secondary MR. And initially you would need to do in those particular cases that you have a CRT, if patient appropriate. If not, then you have 2 ways to deal with this. One, either you continue CRT and guideline directed medical therapy or TMVR. So TMVR, as you know, after the COAPT trial, incorporating the COAPT, the FDA has approved the device, approved the technique of the MitraClip for functional mitral regurgitation. But we still do not have a CMS approval. Was supposed to come in February, March, but that never happened. Gilbert, you want to add on that?
Yeah, I don't know what happened. Maybe the COVID just sidetracked everything that they are supposed to put on the agenda. I think that's the issue. Hopefully they'll approve this soon in terms of the reimbursement, because there are a lot of patients who would benefit from this therapy.
And they also mention on the right side about TMVR that if patient is not a clippable candidate, you need to think about patient otherwise okay for the heart transplant. So in the between you may get ECMO or so. This will be the ideal case. You cannot put a clip. Patient is in acute, severely decompensated heart failure. So use an ECMO device to get this patient to transplant. Although many of these patients have so many other conditions of the kidney failure and so, or CVA, that not an ideal candidate for the transplantation. So now let's come to this point of, Anu, this is what you talked earlier. Let's talk on this issue about what are the echocardiographic features of H2H clip repair. So this is what have been said. Favorable features and less favorable features. Do you want to comment on that? So like where our patient fit in?
No, our patient actually was favorable in every way. I think this is what always the discussion is, whether, the flail gap, the flail length, as more important is the transmitral gradient, which was very low in this patient, and the mitral valve area. Many cases we have seen, especially some elderly females, that they are presenting with the mitral valve area which is less than 4. Those are the cases where we know are not ideal candidate for a clip. But in our case, everything was very favorable in this particular patient.
So this patient, if we just come back to those points, grasping zone more than 10, then for primary MR, flail width of less than 15 and gap of less than 10. While compared to secondary MR, coaptation depth of 11 millimeter with length of more than 2 millimeters. So all those fit in our particular case, particularly from the primary MR point of view?
Yes.
Right?
Yeah, I mean, these criteria were based on average, right? And they were the older generation clips. We now have 4 different sizes to choose from with G4. So I think this is going to be a moving target. And we all done difficult cases beyond these criteria. Yeah. I think it next takes our expert heart team and expertise
time
to do
for
this.
an update.
Yeah. So
No. They actually make the disclaimer below.
Yes, that's
that
right.
these are the
Yes.
criteria for regular way because came from the average trial. But
That's right.
Highly experienced
center,
operator, yeah.
experienced center and highly experienced operator can make less favorable or unfavorable features to be as a favorable
That's
in
right.
terms of the ultimate outcome. So they're very clearly said
Yeah.
on that point of view.
This I think is a guidance, but
Guidance, yeah.
of course you can move around as you get more experience.
That's right.
Go to the next level. Yes.
Overnight.
So therefore, let's sum it up our today's presentation with the two take-home messages. One is the 3-year follow-up of the COAPT trial continue to show benefit of MitraClip procedure in reducing heart failure, hospitalization, and mortality. Moreover, a guideline-directed medical therapy crossover patients, and that's a very important message we got. To MitraClip showed similar 1-year outcome as of the initial MitraClip procedure patient. 1 month KCCQ predicted improvement in 2-year outcomes of heart failure and death, higher in MitraClip group. Clearly, you saw 58% versus 26, associated with improved parameter of health status irrespective of the assigned group. So basically, once you improve the overall, whether with the guideline-directed medical therapy, you had a better outcome at follow-up. Second point, Focus 2020 update of structural heart disease have now incorporated MitraClip in management of refractory heart failure despite optimal guideline-directed medical therapy. With introduction of newer MitraClip devices, G4 and so, procedural success will continue to improve even in patients with suboptimal mitral valve anatomy, especially at the experienced centers and by the high volume operators like Mount Sinai Hospital. So I want to put this as a disclaimer.
Exactly.
And this actually, they do make the referral to a center for the mitral therapy. And of course, Sinai with the surgical, with the number 1, and now we are getting up there in this percutaneous arena, will be a great center for any kind of mitral valve treatment. So coming back to 3 questions, which we always do, following group of moderate to severe MR patients are appropriate for MitraClip procedure in this current COVID-19 era, except symptomatic inpatient with FMR despite guideline-directed medical therapy, symptomatic outpatient with FMR requiring heart failure, admission in 30 days, patient with FMR or DMR with low output state requiring ICU admission, and lastly, inpatient with DMR and severe heart failure and low STS surgical risk. So even in this COVID-19, so that type of patient should go for surgery who has a low surgical risk at present because patient is already admitted, patient is in-house, and so. Second point, following are the favorable anatomic feature for a successful MitraClip procedure except LV and systolic dimension more than 70, flail width less than 15, grasping zone length more than 10, MVA more than 4, we just spoke about it. The LV and systolic dimension of more than 70 is a bad feature. Lastly, following is the true statement about the assessment of KCCQ score in COAPT trial patients. KCCQ score improvement was associated with higher heart failure, hospitalization and death. KCCQ score improvement of more than 5 was associated with lower 2 to 3 year heart failure, admission and death. KCCQ score improvement of more than 10 was associated with lower heart failure, admission, death at 2 years, irrespective of the assigned group. And KCCQ score changes did correlate with MitraClip outcomes at 2 to 3 years, did not correlate. So answer there is very simple C, that KCCQ score improvement of more than 10 was associated with lower heart failure, admission and death at 2 to 3 years, irrespective of the assigned group. Yes, MitraClip people did better, 58% versus 26% in the guideline-directed medical therapy. With that note, exactly on 60 minutes on the dot, we complete our today's session.
I'm checking your temperature.
Okay, well, thank you so much to the heart team members of the Cardiac Cath Lab at Mount Sinai Hospital, and thank you all for joining us to this exciting case. Remember, the recordings of this case are available this afternoon on ccclivecases.org. And also remember that we have our structural life cases every other month on the second Tuesday. The next one will be July 14, right after Independence Day. So thank you so much.
All right, bye-bye.
Bye-bye.
Good. All right,
What a
yeah, thank you.
bullshit.
They're
My
ready.
God.